So CD19 CAR T-cell therapy has dramatically changed the treatment landscape of relapsed refractory ALL patients. However, because these are autologous cell products that often these patients do need bridging therapy. And selecting the right bridging therapy could be a critical decision to optimize the outcome of such patients. A lot of data, including the data with an obe-cel and our own data that we have previously showed, the patients who proceed to CAR T-cell infusion with a lower burden ultimately do better with a less relapse and a better long-term survival. And therefore, if we have an opportunity to reduce their disease burden during the bridging process, and there will be another way to optimize, in addition to CAR T-cell therapy, our post-treatment outcome. So here, but however, the challenges are these patients are refractory to a lot of chemotherapy, so we don't have a lot of tools to reduce their disease burden. And here, the inotuzumab, because of the different mechanism of action to chemotherapy, has been highly effective in this setting, even in high-burden patients. So what we have seen in the FELIX study in the obe-cel data is that these patients were allowed to receive INO as a bridging therapy, and most of these patients, just one dose of inotuzumab was dramatically effective in reducing their disease burden to 80 to 90% to almost less than 5%. So we do know that they are very effective in allowing these patients to receive CAR T-cell therapy in a much lower disease burden, and hopefully will lead to even better outcome afterwards too. So I think that if those patients were to receive CAR T-cell therapy at 80 to 90%, we do know that those patients would have a very dismal outcome. So inotuzumab is allowing the conversion of very high-risk patients to moderate or the average risk patients at the time of a CAR T-cell infusion.